Hey, DNA. Thank you for joining us on another episode of All Access DNA. One of the biggest promises of precision medicine is that each person has their healthcare tailored to their unique genes, environment, and lifestyle. But what happens when the genetic research doesn't accurately reflect the person? Or when a patient lives in an area where genetic services aren't available? I talked to Megan Johnson, she, her, a genetic counselor, about genomic healthcare disparities. Megan recently published research on this topic, and she shares why negative experiences with healthcare providers may impact someone's willingness to participate in future research. We talk about the differences in medical mistrust and medical distrust, as well as why the distinction matters. Let's get started. Thank you, Megan, so much for being on the show today.
Thank you so much for having me here today, Kate.
You recently published a paper in the Journal of Community Genetics about genomic healthcare disparities, and you used data from the NIH's All of Us research program to see if people from historically underrepresented groups report different healthcare experiences. I'd love to know more about what, kind of made you look at these healthcare experiences as part of the larger issues of disparities in genomic medicine.
Yeah. So I largely think it was inspired a lot by my own experience. Growing up in a very rural setting, specialists were very far away, a very long drive. So it wasn't really something that I could take for granted when I was able to access that. And so it really, really mattered when it felt like specialists had time for you. And that started to make me kind of curious. Could the healthcare experience actually be a variable for healthcare inequities? As I got into graduate school and was starting to think about a project and what I wanted to research, it really made me reflect on my own prior experiences. And so when I was looking through everything, I was seeing research focused on access to healthcare and research participation. And the conclusion was we know that healthcare access plays a role in your willingness to participate in research, but it felt like something was missing. And my theory was, what if it's about what's happening during those appointments? Because it's not only about accessing healthcare, but when you leave that room, what does it feel like? How do you feel as a person?
hmm And so that's kind of the term of the healthcare experience, right? Is what is happening during that actual encounter or that clinic visit.
Yeah, it's one part. It's kind of like taking a step back from what we've already focused on and looked at with research participation and access to say, there's more to this. There's more to it than just getting there and participating in research.
Right, exactly. And so for those that aren't as familiar with some of the terminology, can you tell us what is meant by genomic healthcare disparities?
I would describe it as kind of gaps in who's benefiting from the advances that are happening in genetics right now. So there's a lot of genetic research happening, but there are still individuals who have less access to genetic services, less accurate genetic testing due to the tools and the research that we have largely being built from research on individuals with European ancestry.
Mm-hmm. Yeah, and I think that's one of the things that can be confusing for folks outside is understanding what has been studied and learned thus far in genomic medicine and how we do have to continue to diversify and think about inclusion, even if there are framing of those words, but it can lead to really wide gaps in healthcare coverage.
Yeah, definitely. And I think that the goal of this was to look at, our goal is to increase that representation. But even in recent papers, I feel like we're seeing a lot of the same representation we've seen despite all of our efforts. And so, again, it felt like something was missing.
Right. And what's that missing piece to help increase that representation?
Yeah.
One of the things that I didn't have a name for, but I kind of was like, oh, aha, when I was reading your paper was the genomic healthcare disparity cycle. So I like that there was a formal name given to it. But can you walk us through what that cycle looks like in everyday terms?
Yeah. I think that the best way to kind of walk through it is to talk through a specific example. So just making up an example from patterns that we sometimes see in my clinical work. Maybe there's a child who has some developmental delay, but is from an underrepresented background. When they go to a pediatrician, they may be less likely to suspect a genetic cause, less likely to refer to a genetic specialist, and sometimes may even have an unconscious assumption that maybe the family couldn't afford the cost of genetic testing. And I want to be clear that that's an implicit bias. It's not them making a conscious decision that they think that. But then they have to clear that hurdle to get the referral and get to a genetic specialist. And there are the more common things we think about with that, the travel, time off work, all of the other burdens that they have to overcome. And yet, when they get genetic testing, they're more likely to get a variant of uncertain significance, which for the audience, I would describe as, our genes are like directions or sentences that are telling our body how to grow and develop. So that uncertain variant means we found a change in the directions that might be related, but we can't say for certain. And so we don't have a clear answer, essentially. And often that's due to having less data available to confidently interpret what that result and what that specific change means. Without a clear diagnosis, families may miss out on certain resources that can be tied to having a diagnosis. In this example, I think of like school based resources, especially. That is a real world negative outcome. And that may shape whether the family continues to trust the system or wants to participate in research moving forward. So, I guess, big picture, the cycle is that there's barriers to access, there's limited data leading to these real world impacts on families. And that's impacting the trust in medical providers and the medical system, leading to more barriers and a continued cycle.
And I like too how that example paints the picture of it's not just one thing that contributes to why either somebody may not make it all the way to where they can get genetic services, or once they get there, the additional barriers or challenges that may come about. And then I think it also speaks to genetics isn't one and done, right? So a lot of these folks will need continual care, even if they were to get, let's say, a result that confirmed something and it wasn't just uncertain. It's ongoing information, and we know that information changes and evolves. So again, it's not just a one and done clinic visit, it continues. And so the cycle kind of shows how it can continue to feed on itself from the barriers and challenges perspective.
Yeah, because families have to re-overcome a lot of those barriers to come back for their follow-up appointments or to see us
Right.
again.
Right. How can a negative experience with a healthcare provider potentially affect someone's willingness to seek healthcare or maybe even participate in research in the future?
I think that I guess to take a step back, avoiding future healthcare after a bad experience feels very rational. It's very self-protective. And I would say the same for research. If you're expecting that you're going to be treated poorly, then enrolling in research feels like a risk. It doesn't feel like it'll be helpful to you or your family potentially. I think another kind of step back an example of a theoretical patient would be a woman who has a family history of breast cancer and gets genetic testing. If they found a VUS or that uncertain result in a gene linked to breast and ovarian cancer, the standard practice is not to change how we're taking care of you. But that's because we know most of those uncertain results become benign in the future. So we're going to continue increasing breast cancer screening based on her family history. But if she were to later develop ovarian cancer, she may feel that that was a risk that wasn't being managed. So that uncertain result, feeling like it didn't lead anywhere protective, can lead to someone doubting whether the system had an answer when it really mattered to them, whether or not her developing ovarian cancer had anything to do with that uncertain result. She may be less likely to trust the system in the future and wanting to participate in research.
Yeah, and I think we can all say that we've either known somebody, we've been that person who has had some type of experience with a provider, right? That either has made us either not want to go back, change, or hesitant. I think those of us that work in the field are probably more open to changing providers or trying to kind of, even if there might be some barriers, try to kind of figure out some ways around it because we're already within the system. But I can't imagine what it would be like for those that don't work within the system and potentially know who else to reach out to.
Yeah, definitely. And even if a provider that you had a negative experience says, I can send you to someone else, you already have that feeling of, oh, I don't know if I trust who you're going to send me to.
Right, right. One of the things that I thought was key to understanding in the paper was talking about the difference between medical mistrust and medical distrust. And so I wondered if you could tell us more about that and why that distinction is important.
Yeah. So I describe them as medical mistrust is more of that very general, broad wariness of the medical system. I think that a lot of the historical studies have caused that to be the case for some groups of people who have been underrepresented and misused in research previously. It's not about a specific person or situation that happened to them necessarily. Whereas medical distrust is a suspicion or worry about a particular provider or organization. So that may be that they or their family had a bad experience with that provider or organization. The reason that's important is because that distrust is more addressable. If there's a specific bad encounter that happened, we can work to try to change that. Whereas a generalized mistrust, it's harder to make a change for a provider or a clinic that's going to be impactful and resolve that for such a large group of people. The medical distrust, we can really focus on and say, okay, what went wrong? How can we prevent this from happening in the future?
And earlier we had mentioned that your study had used data from the All of Us research program through the National Institutes of Health or NIH. For those listeners that aren't familiar with All of Us, can you describe, what it is and why it's been useful to answering your research question?
The All of Us program is an NIH funded research program that's still open and ongoing. Their goal was or is to build a database that's more representative of the United States population than typical genetics research. So participants can join in a variety of ways. They could be told by their healthcare provider, but All of Us also does a lot of community based outreach and trying to build relationships with communities to build trust in the research system and the medical system. Once participants enroll, they can also self enroll, I should say, but once they enroll, they can fill out surveys that pertain to their health, their lifestyle, and they can also submit a sample for DNA. We utilized one of the surveys called the Healthcare Access and Utilization Survey to look at how individuals are feeling respected by healthcare providers, whether they're receiving information that's easy to understand, and whether they're being involved in their healthcare decisions. What was really impactful about it and why we wanted to use it was not only their goals and their efforts towards building a more representative database, but also that in using this study, we had over 165,000 participants that completed that survey, which helped us identify even really small effects for these groups that have historically not been able to participate in this research.
Wow. Yeah, that I did not realize the number was so big. So for folks that work in genetics, especially those of us that are genetic counselors, are like, that's a big N. We don't always get that from some of our surveys.
Mhm.
So one of the things that I found most striking about the results or what you found from the survey was that 40% of participants said they were involved in decisions about their health care only some of the time or less than some of the time. So what does that really tell us about how patients experience decision making in healthcare?
I'll agree that that was a very impactful statistic we saw come from this study. I honestly suspect that it is related to the shared decision making and that it may be not as consistent across the healthcare system as a whole that as we would like it to be. What was also interesting about this statistic is that it varied a lot. Older participants and men actually reported being more frequently involved. But what stuck out to me was that having a higher education level was associated with feeling less involved in your healthcare decisions. When we were thinking about that, a couple of theories came up, but of course, we have no definitive answers for why that is the case. The theories we had was that there may be a higher baseline level of trust in individuals who have a higher education level. So, feeling a lower need to be involved, right? You're trusting the medical providers to make those decisions, or they may be the ones who are recognizing when they're not being involved in those healthcare decisions. They may have through their education level, a wider understanding of things within healthcare and recognize there are more options here that this provider isn't fully talking with me about. I think it's also worth noting that the desired involvement level is actually very personal and cultural. Not everyone really wants to be fully involved, but to me, this statistic was a big flag that care isn't being individualized the way that we would hope it is.
hmm Yeah, and I always find that fascinating that we talk so much about precision medicine, medicine, personalized genomics, but the care that people are receiving still is yet to catch up to that personalization.
Yeah, definitely.
You particularly found differences for people who had delayed health care because they live in a rural area. This one is an area I'm pretty passionate about, given that I have half my family lives way out in the rural area, and I've definitely seen firsthand the differences in terms of treatment, what they have access to, what they are told, how they participate in that shared decision making. What do you think is happening for the rural patients that may contribute to these experiences?
I totally relate with having family members who are really just out there in the middle of nowhere in terms of accessing healthcare and the concerns there. And it did strike me that this was the strongest and like most consistent negative finding across all of our outcomes was for individuals from this background. I guess a couple of theories that I've had, we all know that there are fewer specialists in these rural areas. They're predominantly at those major academic medical centers. And I don't know if your family is anything like mine, but if they can avoid driving to the big city, they will. I think telehealth is a very imperfect fix. Not only does not everyone have internet out there, but the internet connection can be really hit or miss. And on the flip side, the travel burden, like we had talked about briefly, is just as bad. So we have two kind of imperfect systems to get them where they need to be. I also know that there can be difficulties with pediatricians in these, not pediatricians, PCPs in these very small towns, not knowing how to refer to some of these specialists, especially like genetics, where they're not referring every day. And of course, like we talked about, difficulty with follow up. Did you have any other theories or thoughts from your experience on what else can be contributing to this statistic?
I think, my background is in oncology, precision oncology. And it was interesting. I had two relatives going through not, different types of cancer, but in completely different areas of the country. And one was a large academic, well known research center, one was country hospital. And I think part of it that I had noted was just that the things that were available to the folks at the academic research center was cutting edge, innovative. There were all these options. There were many times under research protocols, so things they didn't necessarily have to pay for out of pocket. And my relative in the more rural setting, I mean, was none of this was either brought up, discussed, mentioned. So I think part of it too is just sort of this dissemination of information as well as things related to like clinical trials that were available.
Things that are really only available at those bigger hospitals.
Right, right. And I want to kind of take a step back and towards the speaking about like genetic information and how we talk about it. Because even for those that work in healthcare, if they're not in the genomic space, it can still be a challenge for them to understand certain, I would say, nuances probably of genetic information. Your study found differences in whether people felt they received information that was easy to understand. What can healthcare providers do differently to make genetic information more accessible and understandable?
I think it's important as much as it's hard to say as genetic counselors that some patients, the first time and the only time they encounter genetic testing and the results is not with a genetic specialist. It may be with their PCP, their cardiologist, their oncologist. And so this is a really important gap worth addressing and really why I wanted to include it in this study. These non-genetics providers are navigating these difficult conversations about genetics without the specialized training, and they may never have expected to have to explain an uncertain variant or inheritance or what it means for family members. It's also hard because some specialties like oncology have some guidance when we have an uncertain result, and some like cardiology just don't. I think some of the biggest considerations for providers in communicating genetic information may be developing some genetic specific continuing education, of course, but especially regarding uncertain results. They're not negative, they're not positive, and I think it can be really hard to navigate those discussions as someone who's not the expert in that and where it's okay to not be the expert in genetics. I also would love for them to have a super low threshold for looping in GCs when they're getting these results that they're not sure how to explain. Especially, we know that there can be some complex genetic testing results, and it's important to be able to loop in the people that the patients need. I think when explaining things, it's important to avoid the technical terms and frequently check in with them about their understanding. And if they have questions, I know I'm guilty of being the one sitting across from the provider, just nodding away, thinking, oh, I guess I'll look it up later. Hopefully, I'll figure it out. And for any provider who's like frequently ordering or considering genetic testing for patients, I would really love for them to consider involving a GC more frequently. There's far more of us than geneticists in the United States, and we can help with the consent, the results, the family variant testing, all of the things. And knowing that it's okay to say, I'm not the expert in this, but I'm going to get you that expert.
Mhm. Do you think that this is a area of kind of growth for the field of genetic counseling or maybe a new territory area that the field can move into is, again, kind of bursting out of those academic research centers, getting more to the primary care setting, getting more towards like rural settings, an area where genetic counselors, because like you said, there's more than there are geneticists, could potentially build jobs and careers in those spaces.
I definitely think that's a possibility in the future. I've loved seeing the research coming out about incorporating genetic counselors into primary care and thinking about how impactful that would be, and I'm sure you would agree, for our families back in these rural areas. And being able to drive 30 minutes over to the next town with a slightly bigger hospital is much easier than an hour or more to the big academic medical center down the street, but could serve as a really valuable connection between that academic medical center and the rural communities.
Mhm. Your findings suggest that income, education, and having health insurance are all associated with some more positive healthcare experiences. What does that tell us about the relationship between the broader social circumstances and genomic healthcare?
Yeah, I don't think it was a super surprising finding that when you're able to access and healthcare and not really worry about getting a giant bill. Health insurance isn't perfect, but having some kind of backup, I guess I would say, to help afford genetic testing or healthcare more broadly, it makes sense that they're having more positive healthcare experiences because they're also less likely to delay care. Like you had said, my family members in rural areas, they delay care as much as they can, so then by the time they're getting to a specialist, it's worse off, it's harder, and I think that can lead to some worse healthcare experiences because you were fine 2 weeks ago, and now you're being told all of these things, and you're concerned, you're alarmed, and this is a provider you're not gonna be able to follow super closely being so far away.
Do you think that plays into kind of the discussion around social determinants of health? So, if you're not having your basic needs met in terms of shelter, food, safety, you're less likely to say, okay, now I'm going to go talk to somebody about this additional test I need for my health if I don't know if I'm where I'm living over the next couple of weeks, for example.
I definitely, could see it being a big factor. If your decision is between going to the doctor and getting some blood work or paying to keep the roof over your head for the next month, I think any of us know what we would have to choose.
Mhm. In the study, you also found some differences based on race and gender identity, but you emphasize that race should not be used as a substitute for genetics or ancestry. And I want to kind of see if we can get this across to folks even that don't necessarily have background in genetics. So why is that distinction important when we talk about disparities in genomic medicine? Why do we need to be very clear on what we're talking about and how we are discussing race versus ancestry?
That was a very important topic of discussion and something that was really hard to reconcile with our study because although we were looking at the more social aspects. So therefore we were using race because that's a socio-political construct that's used to group people. It's not a stand-in at all for ancestry. And if we were doing a study that was really relying on the genetic information, it would not have been appropriate to use that. Ancestry is like your geographical origins, the biological lineage where your family was from. It's genetically meaningful. From your ancestry, these are things we might be able to pick out from genetic testing. We're not going to be able to pick out your race from a genetic test. So, assuming that a genetic risk or concern for certain genetic conditions based on race can lead to missed or incorrect interpretations of symptoms or results. It's really dangerous because just because two people are within the same race does not mean they have a similar ancestral background.
Mhm, mhm. That's very helpful. One of the things too that your paper again sort of suggests or alludes to is that negative healthcare experiences could contribute to people being less likely to participate in genetic research. So then how does that ultimately affect the genetic information we have available to researchers, right? So less likely to participate in genetic research. We've talked about the need for more representation in the databases. We've talked about a lot of folks that are underrepresented getting these variants of uncertain significance. So how does that all tie together?
Yeah, it really, I mean, you've essentially stated it, right? Everything we've talked about, the underrepresentation today means that a patient who goes into the office today is going to have that less informative genetic testing, which is going to lead to those real world impacts that are going to affect your trust in the healthcare system and your willingness to participate in research again. When individuals aren't trustful of the medical system or the research system, which again is a totally valid perception and makes sense given the history of everything that's happened, that leads to continued underrepresentation in those databases, which means we're in this cycle, even though individuals who participate in these research studies may contribute towards making genetic testing more accurate and informing and diversifying our databases for the community. If you're expecting or receiving poor treatment, you're not going to want to enroll in those studies. You're not going to contribute to that advancement. And then we're going to be in the same place in a year from now.
Mhm, mhm. And could you explain a bit more about having that less genetic information from those certain populations make it harder to interpret those genetic test results for those populations?
So, determining whether a variant is harmful or not relies on a lot of pieces of information. But one of the biggest ones is just how common is it in the reference data sets? But again, these are the same data sets that were built largely on individuals with the European ancestry. So for underrepresented groups, these rare but what would become known as harmless variants can't actually confidently be rolled out yet, which is leading to the increased uncertain results. I think a good example of this is prenatal carrier screening, actually. So after you get a negative result, we're going to calculate the residual risk for a child who may have that condition, but that number is going to be heavily influenced by how well studied the carrier frequencies are for the condition in the ancestry group that you're a part of. So it's more likely that someone from an underrepresented population has an uncertain variant in a gene that just wasn't reported, and that we just can't give as precise of a risk for their children based on this genetic testing. And so it's harder to interpret these carrier screening results because we just don't have all of the information we need, and these uncertain variants are so much more common.
Mhm, mhm. One of the things too that was striking in terms of like numbers findings was that 90% of participants reported being treated with respect and receiving healthcare information that was easy to understand. Do you interpret these findings as encouraging along with like the disparities that you identified? How do you kind of pull in some of the that data that has I would say more positive or hopeful kind of connotations to it?
Yeah. Honestly, I think we oversample people with positive experiences.
Yeah.
Those are the individuals who are willing to participate in research and not only participate in the All of Us study, but go through and complete the optional surveys. Something that we noticed is that there was actually a stark difference in the people who registered for All of Us and submitted a sample and did the required portion, and those who continued to do the optional surveys. We lost a lot of diversity in the sample by utilizing this survey, unfortunately. Not all of it, as you can see from the demographics that we had, but it was a notable shift. And what I suspect is that the individuals with the worst experiences are underrepresented or missing entirely from this data set because they didn't even sign up for the research project or they didn't complete these optional surveys. So I
Mhm.
think it's an encouraging number for the people who did participate, but that it doesn't cancel out all of these disparities. And it's really notable that they're showing up even within what I would describe as a very positive skewing data set. And it's possible that the real world gap is larger than what we're seeing in this study.
If we want to break the cycle of genomic healthcare disparities, not saying that there's one answer to do this, right?
Mhm.
Because I think one things that I'm taking away from our conversation is there's layers upon layers upon layers, and different things to look at. What do you take away, or what do you think are the most important things providers, researchers, and patients can do? And you can break it down into three different groups if you want to.
I guess we'll start with providers. I think a big goal needs to continue to be the individualized care. We talked about involvement in healthcare decisions and how that's not what everyone wants. But what everyone does want is to feel that the care is personalized to them. There may also be some benefit in cultural competency training. However, that needs to be developed by these underrepresented groups. It can't just be about them. And also building some genetic understanding, but also knowing it's okay to say, that's not my specialty, but I'll get you to the person and the resource that you need to understand these genetic testing results. For researchers, I think the hot thing right now is community based research and studies, but also considering healthcare experiences when we're studying patients and access and research, not just healthcare accessibility, and to continue diversifying the trial populations and reference data sets so that hopefully we can address at least one portion of this cycle. And, less of a responsibility for patients, but more about lowering the barriers that they're facing. We need to make sure that they have avenues to express their concerns I think in our role, we're very lucky that patients do share their concerns, and we really need to take that seriously. Think about how we can address that and support them moving forward. Knowing about community resources to aid in access and affordability, and data transparency, honestly. How is it going to be used? How is it
Hmm.
going to be protected? And that's something that's come up more frequently with patients that I'm seeing is asking, okay, we're interested in genetic testing, but what do they do with our information? Where does it go? And having those discussions. And I think that that's super important for them to know where their information is. If there was one other thing I could say, it would be that the bottom line from this study and about the cycle of genomic healthcare disparities was to show that it's not about a single fix and that progress needs to happen in all of these different places at once. Healthcare experiences, the clinical encounters, our research and how we're designing it, and overall systemic access, or this cycle is just going to continue.
Hmm. Hmm. Well, thank you, Megan, so much for talking to me today. I really enjoyed the conversation. We'll put a link to the article itself in our show notes, and I encourage others to check it out. And again, like I said, just thank you so much for being here.
Thank you so much for having me here today.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all episodes of the show. This link is also in the show notes for easy access. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Check out our Patreon at patreon.com/allaccessdna and consider donating to get bonus content, submit questions for our guests, and connect with other genetic curious individuals. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This helps other people like you discover the show. All Access DNA is hosted, produced, and edited by Kate Wilson. The logo design is by Designs by NKJ. Thanks for listening, and join us next time.